Susan and I, Senator Collins and I, are here to introduce the Patient Freedom Act. And personally, before I start, I want to make some acknowledgments. Senator Collins has been great to work with. Some of our provisions are frankly still on the margins evolving because she's raised such great issues. How can we better handle it? And so if we say, that's kind of a little bit in flux, not key principles, but just details that, again, Senator Collins has been so good on. Let me also acknowledge Representative Pete Sessions, who has a companion bill that he and I worked on called the World's Greatest Healthcare Plan. And he's introducing that, if he's not already, on the House side. And the bones of that are the same as the bones of this, very closely related. And then a couple other people, John Goodman, a healthcare economist, Phil Passley, a fellow in Shreveport who sells insurance, and others who have just been so helpful to me and to us. Also acknowledge Senator Johnny Isakson and Senator Shelley Moore Capito, who are our co-sponsors on this. So let's talk about the Patient Freedom Act. It has been a Republican principle that power is best held by individuals and states, not the federal government. And if there was a flaw among the many flaws of Obamacare, is that Washington, D.C. arrogated power, taking it from patients and taking it from states. And the American people have still been upset about it. And now we come to President Trump, who ran both to repeal and replace. And when President Trump ran to replace, he has said, either in the campaign or since election, that he wishes all to be covered, that he wishes those with pre-existing conditions to continue to have coverage, that there not be mandates, and that we make it a lower cost. I think, and I think Senator Collins would agree, that there's not many ways to get there, and as far as we know, none better than this. And if you will, this represents a confluence of Republican ideas, and I think it's principally because of that. So, first, Republicans think that if you like your insurance, you should keep it, and we mean it. So we give states the option. You want to put up ours? We give states the choice. We would imagine that Congress would pass legislation allowing states the choice to go into the alternative, which we'll describe. They could opt to stay in Obamacare, or they could opt for no federal help. So California, New York, you love Obamacare, you can keep it. I disagree with it, but Republicans think that power is best held at the state level, not by Washington, D.C., so it's not for us to dictate. On the other hand, if you're speaking of Maine and Louisiana, where premiums have been going up on the exchanges double digits, or Arizona in one place triple digits in 1 year, then those states could opt for something different. We also think that we could cover more people than Obamacare. One of the things we give states the opportunity to do is to say if someone is eligible for a credit, she or he would be enrolled automatically unless they choose otherwise. Automatic enrollment, if you will. Much like when I turned 65 on Medicare, I'm on Medicare. There's no mandate. I'm on Medicare. I may call up and say I don't wish to be, but as a rule, folks remain on Medicare. So we think that this alternative allows us to restore the law of big numbers without a mandate. When I say the law of big numbers, clearly insurance works, health insurance works, by having a lot of healthy people, and you distribute the cost of care for the more expensive to care for over the many healthy. We've had an insurance company model our proposal, and they told us that just by this automatic enrollment feature, you could lower premiums by 20%. And that's while keeping those who are sicker in the pool. Next, we try and make health insurance truly affordable. I've been working in a public hospital for the uninsured for 30 years. And when one of the patients I would see had a deductible of $6,000, why don't you tell them it's $6 million? They can afford $6,000. So if their daughter has an ear infection and she wishes to take her daughter to the urgent care center, then it's coming out of her pocket. Obamacare did not cover that for her. We would pre-fund health savings accounts in the state alternative using an advanceable tax credit, which would pre-fund a health savings account, so that when someone took her daughter to the urgent care center, there would be money in the HSA account to pay for that visit if the HSA was required. We would also have a catastrophic coverage. So if someone gets hit by a car, they would not be made medically bankrupt. the catastrophic benefit would take care of that. And we also have a pharmacy benefit. Now, along the way, to make health savings accounts and, if you will, cash payment or the equivalent of cash payment more useful, we put in price transparency. I was just speaking to a physician this past weekend, and the anecdote tells you so much. She orders tests for patients who pay cash. She went around to laboratories in her community and found out what the cash price was, and for this particular panel, it was $38. So the patient comes to see her and pays the $38. Here's a slip, go get your lab test drawn. And the patient went to the wrong place, got confused, from out of town, received a bill for $690. The doctor calls up. This is crazy. What are you talking about? They were willing to reduce it to $380, but it's either between $38 or $380. If that patient had seen the price schedule when she walked in, she would have said, time out, I'm in the wrong place. So we mandate price transparency for those providers that would participate in this. Lastly, can we put the timeline up? The timeline we imagine is that this year, in a sequence of votes, Congress would repeal Obamacare and replace it, and the legislation would enable states to make the choices that we just described, and that would be in 2018. The states would implement the replacement plan of their choice in 2019, and by the time 2020 rolls around, everything's done. And going back to a woman who was a Trump voter, I always try and imagine her. Again, I'm a doctor. So I try and think of the patients I used to teach and treat at Earl K. Long Hospital in Baton Rouge. And the woman who voted for Donald Trump and just wants Washington out of her life. But imagine that she has a breast lump. She still has coverage under Obamacare, $6,000 deductible. She's trying to make it work. It doesn't work that well, but at least she's got coverage. The only thing that we wish for her to notice as she goes from having this breast lump in therapy, as she goes towards healing of her cancer, is that her coverage gets better, that she gets more power, that she has more of a sense of where to go and not is just told what to do. And that's our goal. Susan?
Thank you. First, let me thank and commend Senator Cassidy for all of the work that he has done on this important legislation. As a physician, he brings a unique perspective because he has actually cared for patients who have been uninsured and worked for so many years in charity hospitals. So I want to thank him for being the lead on this and for all of his hard work. Considerable confusion and anxiety exists about the current status of the ACA and indeed the future of healthcare in America. What is often overlooked in this discussion, however, is that while the ACA provides very valuable assistance to those who were previously uninsured, the system created by the law is under tremendous financial stress. Obamacare exchanges are on the verge of collapse in many states. The co-ops that were created by the law, of the existing 23, only 5 are still in operation. Premiums are increasing in nearly every state with an average increase of 25% nationally. In Maine, on average, the increase is 22%. In Arizona, it's more than 100%. And for a while, it looked like there would be no insurer who was willing to write policies in one particular county. I mention all of that because the point is that significant changes are going to need to be made in order to prevent the individual market from going into a tailspin. Our goal is to increase the number of people who are insured in this country, to help restrain the growth of premiums and to give consumers more choices. We do so, as Dr. Cassidy has explained, by returning options to the state. Ours is, I believe, the only bill that has the unique combination of allowing, in the Senate, of allowing states to choose to keep the Affordable Care Act if it is working for their residents. That means that they would still receive the subsidies, the tax credits, the consumer protections, and they would still be bound by the individual and the employer mandate. Another option, which we call the default option in our bill, and the one which I believe that most states would embrace, would allow states to cover the uninsured population by providing a standard plan that had a high deductible, a basic pharmaceutical coverage, some preventive care such as free childhood immunizations, and it would be financed through health savings accounts. The amount of money that would go to states that choose that option would be the same as the amount of money that they would receive now under the ACA, plus what they would receive if they expanded Medicaid coverage under the ACA, whether or not they have chosen to do so. So it is a generous approach that would allow states to cover uninsured individuals. Now, I do want to emphasize that those individuals could choose not to go into the state plan. They could opt out and instead buy more generous health insurance coverage using their health savings account. Employers and taxpayers would be allowed to contribute further to those health savings accounts, and the health savings accounts would phase out at certain income levels. But they would avoid the cliffs that are so prevalent throughout Obamacare. For example, if you make more than 400% of the poverty rate, your subsidy for your premium is completely eliminated. Similarly, under Obamacare, if you make more than 250% of the poverty rate, you no longer get help with your copays and your deductibles. That's why the increases in copays and deductibles and premiums has an impact even on those who are receiving subsidies if they're below or if they're above a certain income level. Another problem that we have seen with the ACA is increasingly narrow networks. And that means that our consumers are finding that their preferred doctors are not in their network. This can be particularly difficult in rural states with few specialists and whose citizens rely on major medical centers in nearby states. If patients want to continue to see these doctors, they can be faced with enormous costs that are not covered by their ACA insurance. As one Mainer wrote me, President Obama said that I could keep my doctor, and the insurance company says that I can't. That is another impact of Obamacare, and it's one that we are trying to address by having more choices. Many members of this chamber share the goal of expanding access to affordable health care. And over the years, I've collaborated with my colleagues on both sides of the aisle on a number of initiatives. And today, I'm very pleased to join Senator Cassidy in introducing our bill to help ensure that Americans have access to affordable health care that improves choices and helps to restrain costs. I want to make one final point, and that is we recognize that our bill is not perfect. It is still a work in progress. I expect that we will get many ideas from our colleagues for further refinements, and we are completely open to that. But if we do not start putting specific legislation on the table that can be debated, refined, amended, and enacted, then we will fail the American people. This will help protect, moving forward, will help protect families who rely on the program and give insurers time to transition to a new marketplace that is based on more choices for consumers. We want to ensure that individuals relying on the current system do not experience a needless and avoidable gap in coverage. In fact, our goal is to expand coverage to those nearly 30 million Americans who still don't have coverage under the Affordable Care Act. By giving states options that they can tailor to meet the needs of their citizens, I am hopeful that we have come up with a proposal that could attract bipartisan support and move us forward in this extraordinarily important debate.
Thank you.
Thank you.
Any questions? Steve?
Yeah, can you talk a little bit about whether you've gotten any guidance from the CBO on how much this is going to cost, whether the CBO would give you a good score on it actually insuring more people, and on how important it is to keep in place the revenue that ACA provides to help pay for this?
Susan? So CBO has not scored it yet, but on the other hand, this is all done on a per beneficiary payment. And so if you say you have X amount of dollars and this many people to insure, this is the payment you receive. Now, we obviously tether it to what the Affordable Care Act has done. It's worked for the Affordable Care Act, and so therefore we figured it would work for us. Long term, we think we bend the cost curve down. We align the incentives so that states are engaged in managing costs as well as a federal taxpayer. So without a score, we can figure out how much it's going to cost. The revenue is essential. If we repeal all the revenue now, that's obviously going to create a hole. So my preference is that we preserve the revenue until the second reconciliation, at which point we may want to change it as part of tax reform, but it would be part of a comprehensive tax reform as opposed to a piecemeal.
You think of without that revenue, you'd have to come up with a new tax or something else to pay.
President-elect Trump, I'm sorry, I'm used to saying President-elect. President Trump has said he wishes to cover all, take care of those with pre-existing conditions without mandates. For that, you need revenue, bottom line.
I also want to point out that the transparency provisions that Senator Cassidy described earlier should help to bend the cost curve. One of the problems with the Affordable Care Act is it turned out there was nothing affordable about it when it came to reducing the cost curve for health care. If someone is ordered to have a colonoscopy and there are several choices of where to get that done, shouldn't those prices be readily available to consumers so that they can make that choice? I think that's really important, the transparency piece of this bill. One other issue that I do want to make sure that we address so there's no misunderstanding, and that is regardless of what option states choose, We do maintain the consumer protection provisions that are in the ACA. In other words, young people can stay on their parents' policies till age 26. There's a prohibition against lifetime and annual caps, and there is not discrimination against those with pre-existing conditions. And I just wanted to make that clear that that applies across the board.
Yes, ma'am.
Hi, I just wondered how you see the president's executive order on health care that he issued on Friday. Are there some things that you think, how do you see this working in conjunction with Congress on health care? Are you some things the administration should do, and maybe some things they should not do under that executive order to make your work easier?
So the way I look at it, repeal and replace are hand in glove. The president did not repeal the fact that children can stay on their parents' policy till age 26. It remains part of replace. Similarly, he did not repeal that those with pre-existing conditions are covered. Therefore, it remains part of our replace. Again, if you say that this is part and parcel, it's probably more important to emphasize upon what he did not repeal than upon that which he did. What he did repeal, I don't think tangibly affects us at all.
Let me just add to that. I think that the executive order is very confusing, and that we really don't know yet what the impact will be until there's a secretary in place who can interpret the regulations or do the rulemaking to rescind regulations. It's very difficult to say what the impact of the executive order is going to be. And as someone who, regardless of who is president, has always felt that Congress should set the rules and write the laws, we need legislation. There are some improvements that can be made through the executive order process and through the regulatory process, but that by no means takes away the need for comprehensive legislation.
Yes, sir.
Giving states the option of keeping Obamacare is a retreat from repealing it and replacing it. Have you shot this to the White House and McConnell?
I would say what we're doing is moving the locus of repeal to state governments. On the one hand, that is philosophically consistent with where Republicans are. States should have the right to choose. It is also consistent with our long-stated, if you like your insurance, you can keep it. Again, I may disagree with California's decision to keep Obamacare, but Republicans rightly criticize President Obama for reneging on that which he said, you can keep your insurance if you can. Obviously, it's too cumbersome on a federal level to do it on an individual level, so we go through state capitals. So I would say that we're kind of where we need to be. Lastly, to Susan's point, at some point in this process, we're going to need a bill that would get 60 votes. Okay? Just do. Now, if you can say to a blue state senator who's really invested in supporting Obamacare, you can keep Obamacare, but why force it upon us? We think that helps us get to 60. Because the reality is we won't get to 60 if we keep the locus of repeal in the state's capital. We need to move the locus of repeal, to repeat myself, to state capitals and to allow those states to decide the best system for them and fulfill our promise both of repeal, but you can keep your insurance if you like.
And what do the White House and McConnell think about your bill?
I've not discussed it. I've discussed it with Leader McConnell, and he is waiting to see how this kind of sorts out. Clearly, we're waiting for Dr. Price to take, presuming that he is approved, we're going to need that sort of input. But I will say that Price's bill empowering patients have many features similar to this. The use of advanceable refundable tax credits as an example. The use of health savings accounts pre-funded to purchase health services, that sort of thing. So we think it'll be receptive, but obviously there's a lot of moving parts on how it plays out.
You know, the one comment I would add is I believe there's really been a sea change in attitudes on how we should approach this dilemma. Initially, all the talk was just about repeal. And then there was a growing consensus that we needed not only to repeal, but to replace very quickly thereafter. And I believe that most members of the House and the Senate are eager to have a repair or replacement bill at about the same time or shortly thereafter, given the constraints of reconciliation of the repeal.
Yes, sir.
Yeah, I'm not entirely clear on these alternative that states will have. This is am I getting that it's a plan that will be partially funded by the government, that would the states administer it directly? Can you tell us about the alternative choice?
Okay. So do we have a poster for that or not? No, not that one, but that's okay. As Susan mentioned, the sum of money that the state would receive with those eligible had signed up for the exchanges, and the sum of money they would receive if they've expanded Medicaid and or if they had, would be put together and assigned to the state. Now the state could take this responsibility on themselves to distribute this money by advanceable refundable tax credits that would go to an account for the individual. Now you can say, what if the individual doesn't have an account? We've spoken to insurers and other financial institutions, and they say it would be very easy for the state to put out a RFP. We have a certain number of folks who won't even know they have an account. Think of the person living beneath a park bench, or the equally unaware person, the 28-year-old male. And so they may have an account arranged for them. The institution responding to the RFP would become the fiduciary agent for the corpus, but also responsible for the provider network on the catastrophic coverage and the pharmacy benefit. With me so far? Now, the state may choose not to do this, but if they choose to do this, they can take 2% of that amount of money they receive and use it for population health initiatives. This has the potential to have a greater impact than the 2% would on lowering premiums. One example, my state has a high rate of HIV. If our state in Louisiana took that money and put in effective programs to decrease the transmission of HIV, that would have an incredible impact upon population health and upon population expense. As one example, we would live that up to the state because every state has their own issues, okay? Now, if the state chose not to, the federal government could directly administer the credit, in which case it would go through the same process. We prefer the state to do it, but it would be up to the state legislature and the governor to decide.
You know, for the states that have not opted into the Medicaid expansion, I mean, I guess I'm saying, like, what happens if they're like, no, we refuse?
So that's one of our options. Maybe you need to put that back up after all.
Just to clarify, if they did not expand
Yeah.
Medicaid,
They
they
would still-
still get the money as if they had, if they choose the default option 2.
And note that one option the state has is
No
to,
federal help.
no mas.
Option 1.
we don't want it.
Chart.
We don't want to force something on someone. Hey,
Last question. On the individual mandate, I'm sorry, on pre-existing conditions, is that going to be a requirement for every insurance policy that's sold, even in states that opt out of Obamacare? So then aren't you in effect transferring the problem of how you deal with high-risk patients who are sick to the states? I mean, how do you fund if you don't have a universal risk?
You know, I oversaw the Bureau of Insurance for 5 years, decades ago in the state of Maine. And what the Bureau of Insurance did in Maine was create a reinsurance pool for high-risk individuals. And it was financed by an assessment that was imposed on every insurance policy that was sold in the state. So there are ways, alternative ways of dealing with people who have pre-existing conditions to make sure that they can afford insurance. And we do believe in state regulation of insurance. That's why we are giving states these options. But we also believe that certain consumer protections should apply across the board regardless. But there are different ways. There are high-risk pools. Our reinsurance pool in Maine worked well. And so there are different, but the real key is to get as many people in the pool as you possibly can.
Does it effectively create an incentive for the states to require this opt-out?
I don't see how that is at all, Jim. And the reason, you want to address that,
No,
please?
go ahead.
I don't see that at all. Recall I told you that when an insurance company modeled for us the effect of this, you're automatically enrolled unless you choose not to be. Again, restoring the law of big numbers. They said that in of itself lowered premiums by 20%, even maintaining the current health status of those within the pool, already in the pool, just by distributing that cost out. That's the way insurance is supposed to work. All of us good drivers pay for those teenage drivers who perhaps are still learning, right? So I don't see that there's that incentive at all. By the way, I also want to say that we do pre-fund a health savings account. There are some who would argue just for a catastrophic policy. But as a physician, I can tell you, if you manage hypertension, they're less likely to go into renal failure. We pre-fund that health savings account so that someone has the dollars with which to purchase medicine and with which to see that chronic care physician to prevent that more catastrophic disease. And there's a landmark Rand Corporation study from a couple of decades ago, but still considered valid, that those with chronic disease are less likely to seek care if they have a high deductible. So we pre-fund that health savings account, allowing them to purchase that maintenance care, which hopefully means they will never develop that terrible, say, renal failure, to use that example. I think I'm told that that's it. Thank you all very much.
Just a quick question about Betsy DeVos, about the delay of her confirmation vote. Are you at all, given that you're on the health committee, are you at all concerned about this being delayed?
I think the delay was appropriate. We have just received all of her financial paperwork from the Office of Government Ethics, and her financial affairs are obviously extensive, and I support Chairman Alexander's decision to give us an additional week to peruse the additional information that arrived last week from OGE.
Are you
Thank you, everyone. Thank you.
confident in her
Thank you.
approval?
So, I have a follow-up